Hello guys. So now let us learn about general pharmacology. This is a small chapter because the specifics of the all the pharmacological drugs and all will be discussing in that particular systems. So now here we are discussing only the general pharmacology. Okay. So this is all and everything you need to know with respect to general pharmacology. Okay. So general pharmacology is of mainly two main things, that is pharmacokinetics and pharmacodynamics. Okay, pharmacokinetics is what body does to the drug. Okay, so what body does to the drug, whereas pharmacodynamic is what the drug does to the body. Why do we consume the drug? Because for some mechanism of, so to know that particular mechanism of action, that is why we learn pharmacodynamics. Okay, whereas in pharmacokinetics, so to remove the drug or to increase its action or to decrease the action of a drug, so whatever the action that takes place is known as pharmacokinetics. This is the study that we do. Okay, so now let us start with pharmacokinetics and then we'll move on to pharmacodynamics. Okay, so in pharmacokinetics, let us see what are the effects of pH that happens on the drug. Okay, for drug absorption we require same pH. Okay, so same pH is required for the drug absorption, whereas for drug elimination we require a different pH. What does that actually mean? It means that if a drug is acidic, then we require acidic medium. For example, acidic medium is stomach, is where this acidic drug will get absorbed increasingly. Okay, whereas if it is a basic drug, where will the basic component of our body, it will be in the intestines, right? Small intestine. So here where the drug absorption increases. So this is what I meant by same pH and different pH. Whereas the different pHs, if the drug is acidic, so it requires basic medium for its elimination. Whereas if it is basic drug, then it is going to be needing acidic medium for its elimination. Okay, so that's it. With respect to pH, this is the effect the drug requires. Then moving on, let us discuss about bioavailability. Okay, so in IV drugs, 100% of the drug will be available for mechanism of action, whereas in oral drugs it is going to be less than 100%, that is the action of the that particular drug. This is due to first pass metabolism. This first pass metabolism is where in the liver. Okay, so this liver, because oral consumption will go through GIT, it goes to enterohepatic circulation, and then it goes into the that particular organ or that particular cell, it has to go and act, right? So this pass is known as first pass metabolism. Okay, so it has to be metabolized first and then it has to be carried to that particular part where it is required. So that is why oral drugs are of less than 100% of bioavailability. Okay, small intestine is where the maximum absorption of the drug takes place. Okay, remember this small intestine. Why is it? Because there is increased surface area, right? So when there is increased surface area, more of the drug can be absorbed. So that is why small intestine has maximum absorption. So now let us discuss about volume of distribution. If there is reduced protein binding, then the volume of distribution will be high, meaning that more of the drug that binds to the protein, there will be lesser the volume of distribution, right? So more of the drug will be bound to the proteins. So that is why the drugs that are not binding to the proteins in our body will be at a higher volume of distribution. Okay, so remember this thing. Then now coming to clearance, it is volume of distribution into K constant. Okay, so remember this formula, volume of distribution into K constant, okay, is the formula for clearance of that particular drug. Then half-life is 0.7 into volume of distribution divided by clearance. Okay, So 0.7 is a constant value. Volume of distribution and clearance will be given, and we have to calculate the half-life of that particular drug. Okay. Then coming to drug metabolism, it is going to be lipophilic. If it is a lipophilic drug, meaning lipophilic meaning fat loving drug, then it is going to be phase 1 reaction. That the drug phase 1 reaction is how the drug is going to get metabolized in the liver. Okay, that is CYP 450, CYP 450 mechanism is how the lipophilic drugs will get metabolized, whereas the polar drugs which are non-lipophilic will be metabolized by phase 2 type of reaction. Okay, got this? The drug metabolism. Okay, then drug elimination has two orders. One is zero order elimination, the other one is first order elimination. Okay, so in zero order elimination, the rate of elimination is constant. Okay, so for example, if this is a drug, if this is a graph, then the rate of elimination will be constant. Okay, whereas the first order elimination, the rate of elimination is directly proportional to the concentration. As the concentration increases, it starts increasing its elimination. Okay, so this is how the graph would look like. Please go through Google and you will get the graphs of these two drug eliminations. Okay, then these are the pharmacokinetics. Okay, so this is what the body does to the drugs. All the absorption, elimination, all we discussed, right? This is what body does to the drugs. So now let us learn what does the drug do to the body. Okay, so that is why we consumed the drug, right? So for some mechanism of action. So let us see what are the nomenclatures and what are the general things that we should learn with respect to pharmacodynamics. Okay, so that is first thing is efficacy of the drug. What does that mean? It is the maximum effect a drug produces. Okay, so it is the maximum effect a drug can produce, whereas potency is the amount of drug needed for a given effect to occur. Okay, maximum effect our drug can produce is efficacy of the drug. Then potency is the amount of drug. If it is a low amount that is required, it tells that there is maximum high potency. The potency is inversely proportional to the amount of drug. Okay, so if lower the amount, then maximum the potency, right? Just by giving 1 mg itself, the drug is having higher effects, then that means that the potency is high for the drug, right? So that is what it means. Okay, then coming to therapeutic index, it tells the range of concentration for safe and effective usage of that particular drug. Okay, so how to calculate therapeutic index? They are asking in our exams. Okay, so this is how you calculate. Okay, so TD50 by ED50. Okay, so TD50 by ED50 will get a value. So that is how we'll calculate this is the graph that they'll give, and they'll give you the values down here. So this is how you will calculate. These are the dosage of the values. So that is how you will calculate the therapeutic index of that particular drug. Okay, so please know that graph and TD50 by ED50. Okay, so that is how you will calculate a therapeutic index, meaning the range of concentration for safe and effective usage. Meaning if the therapeutic index is high, then even at the higher concentration there won't be any adverse effect for the body. But if the therapeutic index, that particular concentration level, if it changes, then there would be some adverse reactions in the body. So these low therapeutic index drugs are warfarin. I told you, right? Well, warfarin is a beautiful drug, but it has so many adverse effects. That is because of this low therapeutic index itself. Okay, so warfarin is a low therapeutic index drug. Theophylline, digoxin, and lithium. These are certain examples that have low therapeutic index in the drugs. Now coming to major important topic, that is enzyme inducers and inhibitors. What are these things is, inducers, what happens is it will induce the breakdown of the drug that has been activated. Okay, so if I give a certain drug, these are the drugs which will act on it and reduce its activity. Okay, so these are inducers, whereas inhibitors are what inhibits the activity of that particular drug. Okay, so these are the examples: griseofulvin, phenytoin, rifampicin, nevirapine, and all ethanol will cause the reduction of the activity of that particular drug by inducing the elimination of the drug. What happens with inhibitors is this will increase the activity of that particular drug by inhibiting the elimination of the drug. Okay, so best examples are valproate, ketoconazole, ciprofloxacin, erythromycin, and isoniazid and omeprazole. For example, let me take omeprazole. Okay, what happens is omeprazole will increase the activity, or I mean decreases the activity of clopidogrel. Okay, so clopidogrel should not be ever given with omeprazole. Okay, so this is one of the best example, clopidogrel. Okay, so that is how you should remember. So, and rifampicin, I told you when I was discussing microbiology, right? So rifampicin is avoided with ART drugs, anti retroviral therapy drugs, because this causes the this is an inducer. Rifampicin is an inducer which induces the drug elimination. So that is where the ART drugs cannot act on the HIV infection, and HIV infection can elevate. So this is the thing that happens with inducers and inhibitors. Please remember these examples. Okay, then moving down, one of the major questions that they are asking is with regards to drug trials. Okay, so there are phases of drug trials. Please remember there are 4 phases of drug trials. The other 2 I'll explain. Okay, so there are mainly 4 types of phases where the drug trial happens. Okay, suppose I've invented a drug. Now I have to trial the drug whether it works or not. Okay, so these are the phases that a drug company follows. The first is phase 1 is pharmacokinetics and dynamics of the drug. So all the pharmacokinetics and dynamics that we studied, right, this is what they'll study. Okay, so these pharma companies will study the pharmacokinetics and dynamics, how the body reacts to the drug and how the drug reacts to the body. What is the function of the drug towards the body is what is studied in the phase 1. Then they'll test the efficacy of the drug. What is efficacy? We learned, right? Efficacy is the maximum effect a drug can produce, is what is studied in the phase 2. In the phase 3, they will confirm that particular efficacy, what the maximum effect the drug can produce. Okay, so suppose already one drug is existing in the market and that produces a similar efficacy, then what is the even need of that particular new drug, right? So it already has a efficacy that a drug can produce. Then what is the need? Either it should be a low cost or it should be more efficacious than the already existing drug. So this is what the phase 3 will prove. Okay, then phase 4 is post marketing and adverse drug reaction. Now we have released it into the market. Now we'll be starting collecting the data of post marketing and ADR, if there is any adverse drug reactions that is happening after the sales. Okay, so this adverse drug reaction monitoring can be done through various drug management or drug control inspections. Okay, so that is how the 4 phases of the drug inspection will happen. Okay, then phase 0 and phase 5. Okay, so these are not in the 4 phases of drug reaction. Here in phase 0, what we do is, does it work in micro doses is what we are checking. In micro doses is what the efficacy, what is the efficacy, does that work in micro doses is what we are testing in phase 0. Whereas in phase 5, we see the pharmacoepidemiology, whether there is addiction of the drug and all these things will be using. And if there is a particular town or a city that is using too much of this drug, this particular drug, and all these things will be testing in phase 5. Please remember phase 0 and phase 5, because they'll be interested in asking this 2 only, rather than this 4 anyone would be knowing. So that is why they'll go and test the phase 0 and phase 5. Okay, then there are many schedules of the drugs. Schedules are nothing but the rules that the government or the drug company puts up, okay, so with respect to that particular drug. So two main things are schedule H drug and schedule X drugs. Okay, so schedule H is the drugs which can be only got from the pharmacy through prescription. Okay, then the schedule X drug where the drugs have been banned and is not for use. Okay, so these are the two types of schedule. Okay, so there are many other types of schedule. If you are interested, please study that, but for your information, just before your exams, please remember H and X, where H is with prescription and X is no, it is not there, dead. Okay, X. Okay, so no use. Okay, not for use. So this is the basics of general pharmacology you should know. So now in general pharmacology itself, we'll learn about autonomic drugs. Okay, autonomic systems also I'll explain here itself, the basics of autonomic system and the autonomic drugs that are used. Okay, autonomic system is nothing but parasympathetic and sympathetic system, right? So parasympathetic is nothing but relaxer. Okay, so relaxes. Sympathetic is the enhancer. Okay, so remember, generally it is gonna be relaxer and enhancer. Okay, so when I'm talking about relaxation, calmness, vasodilation and all these things, I'm talking about parasympathetic system, whereas sympathetic is where the increase in function or enhanced function, vasoconstriction, all this thing happens in sympathetic system. Okay, so parasympathetic system is also called as mimetics. Okay, whereas parasympathetics that we use are also called as parasympathetomimetics. Okay, whereas sympathomimetics is nothing but the drug that is acting via the sympathetic pathway, is what I'm mentioning here. Okay, so let us see what are the neural things that are present with respect to parasympathetic and sympathetic system. Okay, what are the neural messages that these parasympathetic and sympathetic system sends. Okay, why is the difference? Let us see. So these are autonomic, these are not controlled by us. The motor and all these things are controlled by us. If I'm thinking of talking, I'm talking, right? So that is where the motor function or the voluntary function comes in, whereas these autonomic things are involuntary. This is not under our control. This control is through our brains or subconscious mind itself. Okay, so we are already trained for it. So that is how the autonomic symptom works. Okay, this is an inbuilt system. Okay, so parasympathetic system can be seen in the cervicosacral region. Okay, cervicosacral region, whereas sympathetic is thoracolumbar region. Okay, this is sympathetic. Okay, whereas cervicosacral region is parasympathetic. This is where the nerve systems of the autonomic functions will come out from, is what I'm telling. The cervico meaning cervicocranial and all these things, meaning the cranial nerve 10, the vagus nerve is carrying the parasympathetic system, right? So that is how the nerve will come out. So is what I'm telling about. So there is preganglionic and postganglionic fibers with respect to parasympathetic and sympathetic system. Okay, so preganglionic is from the spinal cord, it is reaching a ganglion. Okay, now from ganglion it is going and attaching to that particular organ. Let us take this as heart. Okay, this is an heart, and so that is where the end result of the sympathetic or parasympathetic action should be. So this is preganglionic, whereas this is postganglionic. Okay, ganglion is where the accumulation of cell bodies will be there. Okay, so when parasympathetic action is happening, it is gonna be the acetylcholine that gets released from the preganglion, and it is the acetylcholine that's acting on the postganglion also. Okay, acetylcholine is the major neurotransmitter involved in parasympathetic system. That is why the name cholinergics, choline, acetylcholinergic. Okay, so that is the major neurotransmitter that is affecting the parasympathetic system. Whereas let us come to sympathetics, where the preganglionic will be acetylcholine, but this is the ganglion. The postganglionic will be catecholamines, that is adrenaline. Adrenaline is what increases our activity, right? Adrenaline action. Okay, so this increases the heart rate, vasoconstriction is happening. Okay, this is the end organ heart, let us think, and sympathetic action is happening. So that is when increased activity will happen. So that is what is called sympathetic function. So these are the two differences between parasympathetic and sympathetic neurotransmitters. Okay, that is why the name cholinergics for parasympathetics, whereas adrenergic for sympathetic. Okay, so this is the major difference. Now let us see what are the receptors of these particular the neurotransmitters are. For parasympathetics, the two main receptors are muscarinic receptors and nicotinic receptors, whereas for sympathetics it is going to be alpha and beta receptors. Okay, so you got it right. For parasympathetic it is going to be M and N, that is muscarinic and nicotinic receptor, whereas for sympathetic it is going to be alpha and beta receptors. Okay, so let us see what are the actions that this parasympathetic system will cause. So parasympathetic system will cause meiosis. Meiosis is constriction of the pupil. Okay, whenever there is no force required, I'll be relaxed, right? Relaxed meaning so pupils will be constricted, whereas mydriasis meaning opening of the eye, dilation of the eye. For example, I see a tiger, I should start running, right? So that is when the sympathetic adrenaline action will start. That is when my eyes start opening and all. So that is why the name mydriatic. Okay, it dilates our pupil. Okay, so this is the major action. So this is where you will go wrong with meiosis. Eosis small. Okay, mydriasis big. Okay, so mydrias, okay, big, the dilation of pupil is there. So remember in that way. Okay, then these are the main actions that these two will form. Other than that, there will be vasodilation and all these things by parasympathetic system, whereas major action of adrenaline would be vasoconstriction. Okay, I'll tell you what is the difference that happens in sympathetics. Sympathetic also will cause the dilation, where and when I'll come down. Okay, just bear for a second. Anticholinergics are the anti-parasympathetics. Okay, parasympathetics relaxed our body, but anticholinergics is where we need not do relaxation, but some issue is there. So that is where increased acetylcholine is getting released. So that is where anticholinergics should be used on the M and N receptors. Okay, so where do we use? One of the best example is OP poisoning, right? So OP poisoning, there is increased acetylcholine. We'll come back to that when we are discussing forensic and toxicology, but for now, just for your understanding, I was telling you the example. Okay, so OP poisoning, there is increased acetylcholine release. That is why we need anticholinergic. Okay, so that is why anticholinergics are there, that atropine, all these things are there, right? So those are anticholinergics. Then acetylcholine esterases. Okay, acetylcholine esterases are the ones which reduces the breakdown of acetylcholine. We saw the sympathetic and parasympathetic, we saw the presynaptic and postsynaptic thing in our general physiology, right? Acetylcholine is what is getting released from the presynapse, and here the acetylcholine receptor is there that will propagate the action potential, right? So if there is acetylcholine will be released between the synapse. Okay, so if there is a component called acetylcholine esterase, which breaks down this acetylcholine. Okay, there is increased breakdown of acetylcholine. To reduce the acetylcholine breakdown, we'll use something called as acetylcholine esterase, which will break down the acetylcholine esterases is there, which will break down the acetylcholine esterase to increase the amount of acetylcholine in the synapse. So there is increased amount of activation or increased action potential, right? So there is increased acetylcholine action. So this is what acetylcholine esterase is used for. This is the major drug that we use for myasthenia gravis, right? So just I wanted to tell you a example of it where the usage is. Okay, myasthenia gravis, this is where we target. Okay, this is all and everything you need to know with regards to parasympathetic system. Now coming to sympathetic system, I told you, right, adrenaline is the postganglionic thing that is there. Okay, postganglionic, it is going to be adrenaline. Okay, adrenaline, I told you, it is going to go and act on alpha and beta receptors, just like M and N receptors in our parasympathetics. It is going to be alpha and beta in the sympathetic system. But alpha has two components, that is alpha 1 and alpha 2, whereas beta also has two components, that is beta 1 and beta 2. Okay, so what happens is alpha 1 and beta 1 are friends and alpha 2 and beta 2 are friends. Okay, that is why alpha 1 mostly causes constrictors, mostly are the constrictors of the vessels and bronchodilators. Okay, please remember this, it is causing bronchodilation, not bronchoconstriction. Okay, because as I see a tiger, my eyes are wide open and also my lungs should be filled with oxygen, right? That is why I'm increasing the breathing. If I start constricting the my bronchioles and trachea, what happens is there won't be enough oxygen that is needed for me to run. So that is why there is increased breathing that is also promoted. So that is why dilation of the bronchioles will also happen. So remember, alpha 1 and beta 1 are the perfect sympathetics. Okay, so both of them are friends, they will cause bronchodilation. Okay, then when it comes to alpha 2 and beta 2, these things are relaxers of heart. So alpha 1 and beta 1 cause the sympathetic system to rise and heart rate was increased, whereas alpha 2 or beta 2 are agonists of alpha 1 and beta 1, where heart rate will be decreased. Please remember this point. Okay, then one more point is, suppose we are using we are using beta blockers, right? Why are we not using beta blockers in asthmatic patients? Okay, because suppose if asthma, already the bronchioles are constricted. Suppose if I use a beta blocker, it blocks the dilation of the bronchioles and too much constriction will happen, right? So that is why we will not use beta blockers in asthmatic patients. Beta blockers with hypertension, hypertension patient is there and he is also an asthmatic. So that is why previous history or medication history is very important to know. Okay, so if a patient with asthma is there and hypertension he has come up with, please do not give beta blockers, because it will worsen the condition of asthma and patient may die. So that is why we are giving the non-beta blocker antihypertensives. Okay, this is how the entire autonomic system and all the autonomic drugs that we were supposed to discuss. Okay, so that's it with respect to general pharmacology. This was a very short chapter and this is more than enough for your entrance exams. Thank you.